The Autism Research Institute relies on the generosity of donors like you to make this webcast possible. If you enjoy this presentation, please consider making a donation. Thank you.
Now, before we get started, I'd like to introduce our speaker. Kelly Barnhill is the director of the Nutrition Clinic at the Johnson Center for Child Health and Development. She's a certified clinical nutritionist with over a decade of experience working with nutrition in children with autism and related disorders. At the Johnson Center, she directs a team of dietitians and nutritionists that has served more than 3,000 children. In addition to her clinical practice, Kelly also serves as the Johnson Center Clinical Care Director, overseeing management and implementation of multidisciplinary care across the practices within the organization. In 2008, Kelly also accepted the position of Nutrition Coordinator for the Autism Research Institute. Kelly is a sought-after presenter, speaking at several national and international conferences each year. You can type questions into the questions section starting now and throughout the talk. These webinars are made possible through generous donor support. If you'd like to contribute, please visit our website at autism.com. And now I'll turn it over to Kelly.
Thanks, Denise. Thank you all so much for being here this afternoon. I wanted to take some time today to talk about autism spectrum disorder and any issues or concerns with growth and weight for children, primarily pediatric patients who have an autism diagnosis. Are there concerns for people with autism spectrum disorder regarding their nutrition? Do we have any research that supports that? What are those concerns and what are those problems? Is it what they're eating or is it what they're not eating? Is the issue what their body is doing with all those nutrients, what they consume them? We don't know enough about all of this, and I want to touch on a little bit in an overview way on each of these topics today. First, I want to talk a little bit about how I view nutrition. What is it? Is it what we eat? Is it what our bodies do with the food after we eat it? Why does that matter, really? Can those issues contribute to the symptoms or comorbid conditions that exist for people with ASD? Clearly, it's a huge subject to cover, and I'll only be able to talk to you about some of those items at a very high-level place, but I hope that it helps you ask some questions. I hope it helps you learn a little bit about where we stand in terms of nutrition in this field today, and I hope that you know, from a research perspective, we're continuing to investigate and push this science forward. I guess the best way for me to think about this is we all know that saying, you are what you eat. There's a lot of truth to that. What you eat determines how you grow, how your brain develops, how you behave, how you sleep, how you feel, and what you eat can contribute to a number of diseases and disorder processes. Sometimes, even if you're eating well, there are still issues, and that's for all of us. Many people have issues metabolizing and absorbing nutrients for a variety of reasons. What does the body do with those nutrients once they take them in? And does it absorb them properly, and does it use them properly? These are all big picture questions that can affect the overall nutritional status and growth of the children that we serve. So in a way to frame the way that I think about this, and in a way to share as much information as I can, given the time limits that we have today, I really wanted to tell you I have two main goals. One, I want to tell you what the research tells us about growth issues and concerns in children diagnosed with autism spectrum disorder. So in looking at all the research that's out there, what are the global areas of concern and interest? And then I want to give you an overview of the role of a comprehensive clinical dietary or nutrition assessment in that process and how it helps move forward clinical care for children that everyone serves, and also for the research to tell us more about what's in the best interest of the children that we serve. So first things first, what do we know about issues and concerns facing the children that we serve? We know really 3 or 4 basic things. We know that children with autism spectrum disorder are more likely than children in the general population to have gastrointestinal concerns. We know that children diagnosed with autism spectrum disorder often evidence feeding behaviors that can be self-limiting or can also be driven by some biological concern, such as low motor tone, for example. We know that children in this population often seek out dietary intervention and dietary treatment, but we don't know what the impact of that intervention had from a research perspective. We have very little information on the impact of that intervention and treatment on before and after growth and nutrition status. And finally, we don't know enough about the nutritional status of children with autism spectrum disorder, but we do know that there is conflicting information out there about total caloric intake, about micronutrient intake, so about the vitamins and minerals that children with autism are ingesting. And so I just want to give you and kind of summarize things in those 4 aspects so that you understand why growth and concerns with obesity or failure to thrive should be investigated in these children. So as I discussed, our kids are at risk of gastrointestinal issues. They have selective or even problem eating behaviors. Other pretty basic things are, in general, as a whole, our food supply is compromised greatly here in the United States. And there are efforts to improve that, but the quality of the food that we eat in general has decreased dramatically over the past 50 to 75 years. And that could also have an impact on the health, and does have an impact on the health of the children that we serve and also the general population. Therefore, I believe that all of these things together make children with autism at risk for nutritional concerns, so nutritional deficiency primarily. And that really, in my mind, can be a function of not eating well, not eating enough, an inability to digest and absorb what they are eating, and all of those things make me think that we really need to be investigating further the outcome status of our children and tracking that carefully over time so that we know how we can intervene and avoid problems in the future. So common complaints seen in children with autism in our clinic and other clinics are here. Bowel abnormalities such as voluminous diarrhea, severe constipation, so children who cannot or do not go to the bathroom for 8 to 10 days at a time, altered stool quality, which is really judged on a Bristol scale, which you can Google that if you're interested, but it allows you to kind of quantify type of stool in a more standardized fashion. And based on a normal stool, in children with autism, we see stools that are sandy or gritty, very sticky, so they can't be easily removed from a diaper or a toilet, very mucousy, sometimes blood. We also know there is some pretty significant behavior associated around GI concerns, such as posturing, leaning over the edge of a table when they have to go to a bathroom, putting pressure on their stomach, hitting their chests can often be a sign and has been noted to be a sign by a number of gastroenterologists as a sign of reflux, severe esophageal damage. Altered sleep habits, hyperactivity before and after a bowel movement, and marked changes in that time frame as well. So leading up to that bowel movement, and then of course potty training is always a big issue in this population as well. And this really isn't new or even controversial information any longer. Clinicians identified and described children with gastrointestinal concerns and autism consistently almost 20 years ago. 15 years ago, when I started working with kids with autism in this arena, things were shifting a little bit. Research had been published that kind of raised some questions, and several books had been published by that time to speak to those concerns, but and they offered some potential solutions. So certain types of diets, such as the gluten and casein-free diet, were touted. There were also a number of resources popping up on the web to allow parents. So this is not new information. However, it was still an exception and certainly not the norm for general practitioners or traditional practitioners to acknowledge or accept that children with autism had gastrointestinal concerns. 6 years ago, the American Academy of Pediatrics published an assessment that was official, and it was a consensus paper on GI symptoms in autism, and they gathered a group of experts in this area who'd been treating children with autism, and that publication was really beginning the process of putting the rest of the notions of GI concerns out there for public knowledge and consumption, and to say children with autism deserve the opportunity for a full-scale gastrointestinal workup to really assess and treat appropriately. And so that's, we're moving on this continuum, and I feel like we are in a place where, yes, we know there are gastrointestinal concerns. Yes, some of the research bears out that there are gastrointestinal concerns that definitely can impact growth and nutritional status. But we're still moving toward recommendations for intervention and treatment. Some other papers have come out since then just to support that issue. This comes from Emory University in Atlanta, and it just essentially is a meta-analysis of literature that's been out for the past 6 or 8 years, and the conclusion is that there is a greater prevalence of gastrointestinal symptoms among children. And I think that that is the most recent paper that speaks to the GI impact on growth and nutritional status. Now let's talk a little bit about feeding behavior. So feeding behavior is something that's intrigued me for a while in our work. I've had the opportunity and the privilege to work with a number of highly regarded individuals. One of those is Dr. Melissa Olive, who runs an exceptional behavioral intervention program for feeding concerns, and I learned a great deal from her many years ago, and I have the opportunity to continue to work with her and collaborate in serving some children. So she really has helped me learn some more about feeding behavior, because from a research perspective, there are fewer than 20 articles that have been published in the past 25 years. Clearly the literature is broader in scope for this concern in other populations, so other developmental delays. We know more, I guess, and more is accepted from a research perspective. The research that is out there suggests that children with autism spectrum disorder have significantly more feeding problems than others, which I think is pretty valid from a clinical perspective as well. And I really feel like future research in this area must look at the cause, the long-term impact, both on growth, on health status, and also on cognitive abilities and function. And finally look at remediation of addressing what's the best way to help children who have abnormal feeding behavior develop a more child-driven, appropriate way of feeding. So what's the scope of the feeding concern? In a general population, they say about 25% of the population under the age of 18 develop some form of feeding concern at some point in time that usually is transitory and goes away. In children with disabilities, the research indicates that at least 25% and up to 90% with physical disabilities have concern, and clearly that's a function of the exact physical disability diagnosis. Approximately 30 to 40% of children with an ID diagnosis may experience feeding problems. Up to 50% of children with illness, prematurity, or low birth weight may experience feeding problems. In children with autism, parental surveys and other research indicate that 90% of parents report a feeding problem. So for me, that's huge based on the impact that it has both on the child's short-term and long-term health and outcome, and also the family. When you have a child who won't participate in eating, it affects everyone in the family system, and that it's important to me to take as much stress off of the families that we serve as possible. So for me, because we don't know really what the outcome is, this is a crucial piece that we need to know more about, because it plays a role in long-term growth status and nutrition status. So the current research is limited, of course, as I mentioned, but the recommendations really are to evaluate the effectiveness of feeding problems, assess the methods that are being used, and look at nutritional status across populations, because we know a little bit in a few very specific populations. We know a little bit about growth status in specific populations, but we don't have any overarching information that can help us develop a plan. So when I look at, and I wanted to touch on this briefly, when I look at the impact of dietary intervention and treatment on the children that we serve, these are all words that reference or reflect certain dietary protocols or dietary elimination strategies that families we serve attempt and provide. So I really wanted to speak to what the research and what the recommendation is now based on those, without delving deep into any one particular approach. So the CDC says this: dietary treatments have been developed by reliable therapists, but those treatments do not have scientific support needed for widespread recommendation. Ultimately, though, in my mind, this information that was published 2 years ago is a huge step forward after the battles that have been fought over the past 15 years. The CDC recommendation for dietary intervention for children with autism is, if you are thinking about changing your child's diet, talk to your doctor or talk with a nutritionist to be sure your child is getting important vitamins and minerals. 15 years ago, the statement was, do not do this. It is dangerous and unwarranted. And so I feel like we've moved gradually and reasonably toward appropriate intervention. So NIMH has also put out some information on intervening with diet and diet treatment for children with autism, and it's also reflective of that CDC language. If you want to try a special diet, talk with a doctor or a nutrition expert to make sure your child's nutritional needs are being met. And this is the same information that we, from our perspective, those of us who have been intervening with children in a dietary way over the past 15 years, that's the language that we use. You must have professional guidance from someone who knows what we're doing and knows why we're doing it to be successful. Because that will maximize the outcome and make it the safest possible intervention for your child. So the American Academy of Pediatrics has also issued a statement, and they say, the science doesn't support this intervention. Talk with your child's pediatrician or speak with a nutritionist. So for me, that is 3 for 3 across agencies entrusted with public health, with recommendations for medical intervention, and those are huge strides in the right direction toward no longer vilifying people who choose to change the intake, the dietary intake of their children. But really, it's a reasonable and appropriate. Ask for professional guidance for people who've been trained in doing this. That's all it is. So why does all this matter? Current research on diets are mixed. Children with autism face risks of GI concerns in feeding, and those things compromise nutrient availability, access, and utilization. And that, I think, leads into the other issue that I was talking about dietary intervention and the need for professional guidance. So on a big picture level, we need to be understanding that all of these variables can have great impact both short and long term. And when we, on an individual level, choose to intervene, we absolutely need to be doing this with as much data-driven from a full assessment and feedback from an appropriately trained clinician as possible. So why is dietary research important? Why does it matter if we're tracking whether kids are getting enough to eat and whether they're growing or whether they fall into either a category of overweight, obesity, or failure to thrive? Well, in my mind, it's really twofold. Families want the best for their children, and they continue to implement dietary intervention despite the fact there isn't a lot of positive research out there that proves that it provides a beneficial impact on either weight gain, GI status, or behavior. Also, those of us on the front line, clinicians, diagnosticians, other providers, are at a loss to provide true guidance unless we're professionally trained like some of us. So people who families interact with every day don't have the resources available to guide those families in any particular direction because there's no official research stance. So what do we know right now? There are a few researchers out there who were looking at nutritional status and author growth status of children with autism spectrum disorder. One group is in excuse me, Spain, and their work they've published several works studying a very specific population there, and they essentially say that children with their conclusions are that children with autism tend to fall into a lower weight category and a failure to thrive risk from a growth perspective, and they tend to be deficient in a number of nutrients than their otherwise healthy, typically developing peers are. There's another group in China that essentially has the same conclusions from their work. There was a recent publication last summer looking at kind of an analysis of and a review article of all the information that has been published so far, and this article in particular points out a number of discrepancies in conclusions in research because there are several studies looking at other aspects of intake, so a child's vitamin D status or a child's mineral status, for example, and they also publish growth data in those. But it's not the primary research question. And those studies have some differing information and responses and conclusions. And those are very clearly addressed in this article. So we did a 2-year growth status study of children within our clinic, and it was recently published this summer, and surprisingly, the results indicated that there were very few growth differences, honestly, in our ASD kids and our control kids. Failure to thrive risk was consistent across both groups. Prevalence of overweight and obesity was consistent. The only difference was in a very specific portion of the population that we included in this, that were included in the study, and that is that girls with autism had significantly lower BMI than their counterparts. But at the group as a whole, there were no differences. And for me, as someone who pays attention to this issue and thinks about it as often as I do, it was surprising because in our clinic and in our clinical care, I would say that the majority of the children that we serve trend toward lower weight or failure to thrive concerns. And that could be that it's a self-selecting population. People come here for help because they know there are issues there, and this was a randomized study. But it was interesting for me that those results didn't really bear out with what we see in a clinical way. So what does all of this mean from a clinical perspective? Regardless of a diagnosis, there's no question that a healthier diet and monitoring what's going in and growth status is better for everyone. So there's really no need to discourage it. And so for me, the recommendation is a comprehensive clinical assessment for any child diagnosed with autism as a referral point from their pediatrician, because that will allow monitoring, tracking, and intervention if needed with an appropriate trained professional. So what does that clinical assessment look like? That paper that I mentioned earlier, the 2010 publication, the consensus paper that was chaired by Tim Bowie at Harvard, recommends a dietetic workup as standard of care for children with gastrointestinal concerns, period. That's still not the case, and that's not what's happening. That 2014 paper that I showed you from the Emory Feeding Program recommends a comprehensive feeding assessment and dietary assessment for every children presenting with autism. So in my mind, you know, we know those statistics that I've mentioned, both in terms of gastrointestinal concerns and also feeding concerns, that pretty much covers a huge portion of this population that we should be seeing in clinic to assess, document, and recommend and intervene if necessary. But it's not the standard of care that's happening right now. Why is this happening, and why is it important that we try to rectify and remedy this? In my mind, physicians are simply not trained to provide appropriate nutritional care, and they don't have training in medical school to fully understand the impact of nutrition on their patients. There are more and more physicians out there who do that, but in the scope of training for the large majority of practicing physicians in the United States today, they've had very little exposure to nutrition, and the demands on their time are so significant that there's not a lot of time to step outside the box of their original training. So families can access information and do this, but in a perfect scenario for me, we honor those recommendations for a dietary assessment, a growth assessment, that have been laid out in the literature, and start standard of care treatment for the children we serve. So what does a baseline clinical nutrition assessment look like? It's very straightforward. Most people don't really understand what a nutrition clinical assessment looks like versus a medical physical, but there are some differences, and I thought this would be a good time to kind of lay out for parents and also practitioners why this is an important tool and why this should be the scope of care that you receive if you seek out help from a dietitian or a nutritionist in serving your child. This is really the fundamental content of what should drive care from a dietary perspective for your child. So a nutrition physical looks at a lot of different things. Sometimes families are surprised when they come in and we work with our child life specialist to do kind of a quick 15 to 20 minute review of a child. So looking at fingernails, if we can have a child open their mouth and let us see what their tongue looks like, what their gums look like, what do the whites of their eyes look like. We can learn a great deal from their skin, from their eyes, from their fingernails, from the quality of their hair, and that tells us a little bit about current nutritional status. Then we perform anthropometric measurements. We look at food intake. We build a comprehensive health history for that child from prenatal care, if we can do that. And then the final component really is the biochemistry that's involved, the data that we need, and that involves a laboratory requisition typically in conjunction with in some instances, dietitians and nutritionists are not allowed to order labs, and in that case, they work in conjunction with physicians who do have that requisition right. So why do we do this? I mean, I've been through this several times already, but we do know that overweight and obesity is a concern that is noted in some of the research literature. We do know that failure to thrive is significant in this population that we serve clinically, and we do know that malnutrition is a valid concern for every child who walks in the door, regardless of an overweight obesity status or a failure to thrive status. We have a number of kids who come in with calorie malabsorption, so they can be eating 2,500 or 3,000 calories a day and still be below the 25th percentile for height and weight. They're just simply not, in most instances, accessing the nutrition that's going in. In terms of protein malabsorption, that can also be an issue for some of the children that we serve because, one, they self-limit to avoid many proteins, and therefore that compromises their amino acid status and their ability to build muscle, bone, tissue to grow. So that nutrition physical that I mentioned, it involves a number of different things in addition to that brief sort of looking for very specific nutritional deficiencies issue. It also involves the anthropometric measurements, an assessment of body composition, a full assessment of vital signs. So nutritional status can certainly impact a number of things, and heart rate and blood pressure are a few of them that we overlook. And getting those vital signs recorded and documented and followed allows us to kind of look at impact of anything that we change from a dietary or nutrient perspective over time. We try to do a physical assessment of the child's fluid status, so are they dehydrated, are they well hydrated? We do a full oral health assessment, so in addition to just checking gums and the tongue, we also try to walk through oral health history with families. We try to learn about more about teeth eruption, any issues with cavities, any issues with tone or fluid pooling in the mouth. And then finally we try to do an oral motor and dysphagia screening, which is a pretty significant concern both for kids who surprisingly are young and they have not been identified as having those concerns yet, and also older children who the parents have had an inkling that there could be an oral motor concern for some time, but they just haven't had it evaluated, or no one has pointed out that, oh, that could be contributing to his desire to only eat this type of food, for example. So what kind of anthropometric data does one collect to track? We look at weight for age and height for age, weight for length and height, BMI, which is a calculation based on those measurements. We track changes in growth rate over time, and percentage IBW allows us to, all of those things allow us to track stunting and wasting. And in this population, as we track failure to thrive concerns and children who bounce along at the 5th percentile or fall from the 25th percentile below the 5th percentile and have trouble kind of coming back from that, this data helps us understand what's happening in almost a real-time basis. And then we do a full food intake record and analysis. There are a lot of practitioners who feel comfortable cutting corners, and I can do that in certain circumstances, but I'm not comfortable cutting corners in taking data for the children that we serve here, because I think it's vitally important to document intake over time. And that really typically involves being very specific about every food item that goes in, documenting quantities, preparation methods, any beverage at all, including water that is consumed. And I also like to track the amount that you offer the child that's on the plate versus the amount that's consumed, because that gives us information as well. And why is it important? It allows us to look at nutritional quality. It allows us to assess a caregiver's perspective about food and nutrition. It gives us some information about the balance of solids versus liquids that a child eats, and that's kind of important when parents come in and say, my toddler will not eat anything. He's very picky about everything that goes in his mouth, and once we have that food intake analysis completed and we see that the child is getting 32 ounces of whole milk every day, which is an enormous number of calories for a tiny little body, he's not hungry. That's why he's not eating. And so shifting that balance allows us to serve, that information allows us to shift the balance and serve children better. It allows us to evaluate eating patterns, any food JAGs, so where a food is preferred, and then rejected. It allows us to identify any major food groups that might be missing and document those. It allows us to identify daily patterns, so children who refuse breakfast consistently or children who must have a snack at 10 o'clock every night. It just gives us the data to support any recommendations we make as we move forward. The other thing that we like to track is mouthing of non-food items. So this is a feeding behavior that's important that comes up often with a food, with that food intake analysis, and also just a nutrient assessment, that whole nutritional workup in general, because it identifies any mineral deficits or deficiencies the child might have. It allows us to talk about all of these other things such as self-limiting behavior, potential allergies or intolerances, any need for feeding therapy, and it allows us to talk about texture and temperature concerns, so a child who will only eat room temperature food, and how do we use that to our advantage as we try to increase nutritional quality over time and intervention. So the last component really that I want to talk about in terms of a nutrition physical is a laboratory assessment. And this is something that I firmly believe every child should have run, if not annually, because I don't know that there's need to run any of these panels annually unless there is an abnormal result at some point in time. This is information that tells us about an individual's nutritional status. It also gives us information that allows us to understand how that person's nutritional status can impact health, behavior, sleep, cognition, etc. So I feel like the first 5 on this panel are vitally important. So a complete blood count and a comprehensive metabolic panel, which a pediatrician can order for you, a nutritionist can certainly recommend that it be ordered. Those give you a great picture on what might be happening from a red blood cell count that could indicate anemia, what's happening with blood glucose, for example. Also, and in saying that, I should say all of these labs I prefer to be run in a fasting state first thing in the morning, because the research tells us that having those numbers drawn consistently, same time of day, with the same rough standards of fasting for 6 to 8 hours is appropriate. So I always track vitamin D with the children that we serve. Pretty much we know most of the children that we see will be vitamin D insufficient or deficient, depending on whether they have had supplementation currently or in the past. We run a full thyroid panel because that allows us to see if the thyroid is functioning appropriately, because we know the thyroid can play a role in growth concerns. We run a full iron panel that allows us to see bound and unbound iron, blood iron. We also add ferritin to that because that allows us to see stored iron levels, and all of those kind of speak to the picture of anemia. There is also some research out there that says children with ferritin levels below 40, for example, have more difficulty sleeping, staying asleep, going to sleep and staying asleep than children with higher ferritin levels. So we check those so that we understand and have information in a big picture way. Additional mineral assessments can be ordered based on practitioners. requests. Sometimes zinc levels are recommended based on the pica observation that I mentioned earlier. And there are a number of functional medicine exams or functional nutrition exams and testing that can also be added to give very specific information on micronutrients such as vitamins, minerals, essential fatty acids. Those tests can give us information on gastrointestinal function. And all of those results can then help us paint a picture for where the child is right now and how we best serve him or her in moving forward. And that becomes a key component of the toolkit that helps us get where we want to go. So what value does all of this provide? They are fundamental to what happens next, in my opinion, because if you have a low ferritin level and you're struggling sleeping, you don't need to be trying everything off the shelf. You don't need to be a frustrated parent who is sleep deprived yourself if we know that your child is borderline anemic with low ferritin and we add iron and he can suddenly start sleeping. It's a piece of the puzzle that we need to respect. Using this data with a trained and knowledgeable clinician can then guide everyone through an appropriate dietary intervention. So you're not grasping at straws or trying something that you've read about or doing something that your next door neighbor mentioned. It's a comprehensive, and I don't want to discount that either because I really do understand how we get here, but this provides us with a comprehensive perspective on what to do next if we're tracking intake and growth. And that leads to a better outcome for your family, for the child, and it benefits the community too through building a body of evidence-based knowledge that will serve children with autism in the future. So in summary, what are reasonable recommendations and what does that look like? A diet plan based on the deficiencies and excesses determined by that nutrient intake analysis or food intake analysis, the child's growth status, and the nutritional data we have from the labs that I mentioned. Nutritional supplementation could be defined by that laboratory data. So a vitamin D supplement might be necessary based on the lab data. An iron supplement might be necessary based on laboratory data. If there are other more complex labs drawn and you realize the child might benefit from B vitamin support, that would also be data-driven and based on the laboratory results that we have. And all of this data really provides a baseline, and then at opportune moments, it offers benchmarks for evaluation of that intervention on an individual basis. And from a research perspective, it allows us to collect that data and then share it with the population at large on publication so that it can drive care for other children as well. Thank you so much for your time. I budgeted some time for questions today, so if there are any questions out there, I'm ready for those now.
Yeah, we've got a few questions. One of the first questions is about BMI.
Okay.
This person is asking about using BMI in the autism population and about sort of how accurate those measurements are for kids. Do you use sort of a range, or how do you feel about using that when we're looking at a young population?
I think that's a great question because I struggle with it as both a parent and a clinician and also as a researcher, because right now the research standard for us is in fact BMI. In a clinical setting and on a clinical basis, do I think that BMI accurately defines any labeling we may or may not want to put on a child? So for example, if we're tracking BMI for a child who is underweight and not, has very low other anthropometric measurements as well, but not falling off a scale or evidencing other issues such as malabsorption, that could be who that child is supposed to be. And the flip side of that is we have children who have higher BMIs who are very healthy in their bodies. And so that's where like the clinical acumen comes in, I think. And you really have to be able to say, this is who you're supposed to be, and we have the data that shows that over time. So from a clinical perspective, in a pediatric or adolescent population, I don't think that a random evaluation that says we have a BMI of 26.5 and therefore your child needs to be on a diet is the data point that should drive that. I don't think that's fair to the child, and I don't think that's fair. I don't think that's good clinical care. I think that that data point coupled with a full picture could make that case, but it's certainly in this population not the be-all and end-all.
Great. Okay, so we also have a question here relating to that. This person says that their child's BMI sort of goes really up and down, that they'll eat a lot for a while and then they'll kind of skinny out and then they'll eat a lot again. So she wants to know if that's normal, if you see that quite a bit, or if that's more specific to this.
We see that quite a bit.
Okay.
I think that that is a pattern that we see in general in the pediatric population, where we have children who will have huge growth spurts, and they will obviously be much thinner over a period of months or years, and then stagnate, gain weight, and then grow again. And that typically we see in the 9 to 14, 15-year-olds that we serve. And it's a pattern that we've seen time after time after time. If the red flags for me would be, are there other concerns with the child's weight loss, for example? So is he healthy? Does he have is he experiencing a lot of immune system concerns? Does he suddenly have any bowel symptoms like diarrhea? And with that symptom kind of picture, then there might be other questions we would ask. But in general, if the child is healthy and has just followed this trajectory and pattern over time, I think that that's fairly common.
Okay, the last thing related to BMI then, this person is asking about, so if BMI is not the only measurement, what other things do you look for when you're assessing for failure to thrive?
So we look at big picture in terms of failure to thrive. We look at weight for height or weight for length as one component, which is a similar but not identical measurement to BMI. I place a lot of merit in other anthropometric measurements such as mid-arm circumference, because that is something that's been studied over time in other populations that malnutrition and malnourishment are big in, and there is a huge body of data that tells you tracking that in a pediatric population allows you a better understanding of true status. And so we track that regularly as well, and that's something that we look at. I look at, often what I track is gastrointestinal status, caloric intake, and who the child is. And I also, and it's surprising to me, and this is tangential, but for populations that we serve, we have children here from countries all over the world, and consistently families will come in and say, my son has been diagnosed failure to thrive and I'm struggling and I'm not, and the child is quite thin, but when you overlay that child's growth status on an accurate growth trajectory for their, I mean, I've seen children from Pakistan, I've seen children from India, I've seen children from really, truly all over the world, and when you use nationalized standards from their country of origin, suddenly that child doesn't look like a 1% or a 2%, an under 5% child. That child is within a normal, 25th percentile for who they are supposed to be. And we neglect to think about that here in our clinical care. We just do.
It's a good point. A nutritionist is actually asking about that, if there are places where they can go to get training specifically about issues with nutrition and autism, if there's a training or something specific.
I think the best resource that we have available now, frankly, is through the Autism Research Institute and the online resources available there. I don't know that there are any real-time, there are very few things available right now at the moment that help professionals learn further about this, but there's an abundance of information available through ARI that can at least get professionals started in that direction.
Okay, great. This parent is asking two questions. The first is about, do you feel like when people are doing nutritional assessment that school ends up being this sort of black hole where you don't get a very good picture of that? So that's the first part. And then the second part of her question is about recommendations for parents for helping them have a full nutritional assessment covered by insurance. Have you seen those kinds of tests covered?
Yes. The first part of that question really is the school black hole, and that really depends on, it's a case-by-case basis. So many of the families that we serve, their children are quite young and are in full-time programs, either home-based or clinic-based. And most of the clinics that we work with are very well schooled in appropriate and inappropriate food choices for each of their children that they're serving. For our older children who are in a kindergarten or above program who have access to that information, to that food, and teachers or assistants or aides who have a lack of access to information on what's appropriate, that's where the black hole comes in. And so from a parental perspective, my approach has always been to be as kind as possible and flood anyone who would have contact with that child throughout the day with as much information as possible to make sure the child is safe, and that if the child is eating something that should or should not be consumed, the parent gets the feedback. Now that becomes a different ballgame when you hit puberty and adolescence, because then you have to kind of work with your child on that too. But in general, building that communication bridge with the school solves a lot of the problem with not really understanding what's going on at school with snacks and lunches. And in terms of the second question, yeah. Okay, can I think on that one? Can we come back to it?
Yeah, that'd be totally fine. Yeah.
Okay.
Okay, so the next question is about recommendations for finding a locally trained and knowledgeable clinician or nutritionist. So do you need somebody who's very specific to autism, or would a general nutritionist, if that's who's available in your area, be following similar guidelines? What can they do in that vein?
So I think that there are probably a dozen highly skilled nutritionists who've worked in this field for a decade or more across the country. And one of the beauties of being a dietitian or a nutritionist is that you can provide, in most instances, with a very few pockets of states that don't allow it, you can provide consultative services from afar. And while that's not ideal, because you've got to trust the family to with a number of things. If you simply cannot travel, and we understand that parents of children with autism sometimes have great difficulty traveling, and in that instance, what we typically do is have a family visit with a local dietitian or nutritionist to do that full workup that I mentioned. So gather all that data very specifically when we cannot put our hands on the child individually, and then use that data to work on a plan. We also have, in this group of 10 or 12 people that I'm speaking of, there are a number of us who consult with other practices on a regular basis. I hesitate to say that you can find exceptional dietitians or nutritionists everywhere now, I think, in a lot of ways, but finding someone who understands the specific nuances of a child with autism can be tricky, because the research, as I mentioned, that's out there doesn't really support the idea yet that this is something we need to be focusing on and looking at. I mean, we have recommendations, we have some conclusions, but we're still not standard of care there. And so if you walk into a standard of care practice, a standard practice, the likelihood that they can help you in the way that your child might need help is much less, I think. And then I guess to go back to the insurance question now, many of our kids now get coverage for full workup. it totally depends on insurance plans and policies and coding, but I would say 75 to 80% of the children that I see in practice get out-of-network reimbursement for the services that we provide. So it can be done, and working with the practice that you see, it could be paying out of pocket and then getting reimbursed, but in most instances here, we are successful in helping families get reimbursed.
Right, and I can comment on that a little bit too. With insurance, the other thing is if it's coded incorrectly the first time, may try again. That sometimes happens where people turn in tests and it was coded incorrectly, or maybe a slightly different code that is still accurate would apply. So you can usually work with both your provider and your company on that if you run into those sorts of things. Kelly, one more question. I know you've got to go, but I've got a lot of questions about adults. There are a lot of people who are asking for more information about what happens in adulthood, particularly with obesity issues. As people become adults, they're much more private about if they're experiencing constipation or some of these other problems. So do you have any just sort of general tips or some resources, or maybe this is a great topic for a soon-to-occur webinar in the year to come?
That sounds like a good plan. I think that there are honestly a few publications out there on this particular issue from AGI. I know that that was some information that I shared with them for future publication, and I don't know if it's on the AGI website, but I do feel like I saw it in an AGI newsletter within the past year.
Yes, we have some resources on that. You're correct. So I can point people to our website at autism.com for some of that.
And so I think that for me, and this is speaking to the general population as we age and if there are any weight concerns, that a full assessment that would, as an adult, include those panels that I mentioned, but also other things that we need to worry about as we age, done to assess, get the data, and then help with a plan forward is the wisest thing to do, because if you enter adulthood and you face an obesity situation, the longer you go and the older you get, the increased likelihood for other issues to occur, such as diabetes, heart disease, cardiovascular disease, lots of concerns there. And so getting the data that helps us drive that would be the basic recommendation I have. Looking at the material that you can direct people to is appropriate, but I think it's worthy of a longer conversation, because I think that's one of the things that we need to be talking about openly now.
Okay, great. Well, Kelly, thank you so much for this. For everybody who's still here, be sure to check out our website at ariconference.com. We've got a lot of talks coming up between now and the end of the year, so you'll want to check out all those topics. And Kelly, we look forward to seeing you again in a few weeks.
Thanks so much.